Dear colleagues and fellow researchers, esteemed members of the committee, I welcome you to my complex exam presentation of my ongoing doctoral research. The title of my PhD thesis is The Role of Endoscopic Interventions in the Management of Pancreatobiliary Diseases. My name is Bálint Gellért. I'm a PhD student at the CTM and work as an internist and a gastroenterology fellow at the Department of Surgery, Transplantation and Gastroenterology at Semmelweis University. My supervisor is István Ritz, my SMS is Anett Ranc, and the statistician is Daniel Veres. And my vision with my scientific work is to reduce the pancreatobiliary disease-related morbidity and mortality. And to accomplish this, I intend to enhance the safety and efficacy of different endoscopic interventions used in the management of these disorders. With this mission in mind, I'm currently working at two specific projects. The first is investigating the role of different ERCP techniques in patients with Roux-en-Y gastric bypass anatomy, and the second is about improving the endoscopic management of ward of pancreatic necrosis. So let me continue with the introduction of the first project. Roux-en-Y gastric bypass is a bariatric operation, and as you can see it in the bottom figure, it is still the second most common performed bariatric surgery worldwide. And this operation substantially modifies the anatomy of the upper GI tract, and interventional endoscopy of the bypassed stomach or duodenum requires special expertise and training in these patients due to the challenges posed by the unique surgically altered anatomy. As it can be seen in the boxes, the problem with these procedures is that the more effective ones have also been associated with more complications. This controversy has created a dilemma in therapeutical decision-making, which we aim to clarify with our project. So we decided to perform a systematic review and meta-analysis and formulate the clinical question whether any of the three techniques is better than the other two in terms of safety, feasibility, and efficacy. And conducted a systematic search in three major databases, following which 67 studies were included in the final analysis, enrolling the data of more than 2,000 patients. Almost all of the included studies were retrospective in design. And let's see what we found. The first forest plot is a summary forest plot representing the proportions of successful access to the papilla of Vater with each ERCP technique. This is a fundamental aspect of the procedure itself and of our study, because the inability to reach the papilla is the most common reason behind procedural failure in these patients. So the outcome parameters are proportions that were extracted from each ERCP group, from each study, and they are pooled together yielding pooled proportions with 95% confidence intervals, of course, and this resulted in numbers between 0 and 1, where 0 meant no success and 1 meant that all of the procedures were successful, and that were then converted into percentages that are highlighted on the slide. So according to our results, there may be a significantly lower chance to reach the papilla with the enteroscopy-assisted ERCP compared to the other two techniques. And it can be seen that the difference grew even more significant when the proportions of biliary cannulations and ERCP success were investigated. And the fourth forest plot represents the proportions of overall complication rates, which is also a crucial outcome for our study. And if you can remember, according to previously published data, it's supposed to be lower with the enteroscopy-assisted ERCP. But our results show that though enteroscopy-assisted ERCP yielded lower complication rates, the difference between the group was not significant. And it can be seen that the difference remained not significant between the groups when the individual complications were investigated. We can't say that these are mathematically proven facts, of course, due to the retrospective design of the included studies, but these tendencies can at least serve as basis for future prospective studies. So our study has several strengths compared to previously published meta-analysis of the subject, including the very strict eligibility criteria for patient and intervention selection. And I think that also the very rigorously applied principle to include one data per patient into statistical analysis is also a strength of our work. And according to our knowledge, this is the first meta-analysis investigating bile duct cannulation rate in this population. Unfortunately, the inclusion of the many retrospective and single-arm studies is associated with inherent limitations as well. To summarize our results, we can say that EDGE and LA ERCP might be may be better in reaching the papilla and performing a successful ERCP than enteroscopy-assisted ERCP, while being as safe as enteroscopy-assisted ERCP. The future implications of our work could be the preference for EDGE and LA-ERCP over enteroscopy-assisted techniques. And as for research implications, I think this study reveals the need for more prospective studies and head-to-head comparisons between these interventions, and cost-effectiveness analysis could also help the decision-making. And also, as EDGE is still being quite a novel procedure, its safety factors could also be explored in greater detail. Our manuscript was submitted to a D1 journal that asked for a major revision that we are currently working on. So I would like to continue with the second project, which is a suggestion for a multicenter prospective trial to compare two endoscopic treatment strategies in the management of pancreatic ward of necrosis. Acute necrotizing pancreatitis is a very severe condition associated with many complications and high mortality rate. And one of its late local complications is the development of a necrotic mass with a well-matured wall that is called ward of necrosis, abbreviated as WON. And if certain criteria indicate that these WONs must be drained, and nowadays we know that this should preferably be done by the endoscopic placement of plastic stents or aluminum opposing metal stent. If it's in itself not enough, then the removal of the necrotic content should also be performed. That is called necrosectomy, and this should also preferably be done with an endoscopic technique. This is illustrated here on these figures. But there are several unanswered questions surrounding this topic of this direct endoscopic necrosectomy. Some of them are here listed on the slide. And we wish to focus in our study on the timing of the direct endoscopic necrosectomy, and think that the study could be built around the clinical question whether a regularly performed direct endoscopic necrosectomy compared to an on-demand fashion performed necrosectomy could lead to improvement in wound resolution rate, morbidity, and mortality rate. This is again a suggestion for a clinical trial with the aim to improve the safety and efficacy of the endoscopic step-up approach. The summary, the first project was submitted to a D1 journal and which asked for revision, and the second project protocol is under preparation. I presented the first project on a few Hungarian conferences and also on major international conferences in form of an oral presentation. And another important occasion should be mentioned here because the first laparoscopy-assisted ERCP in Hungary was performed March this year at our clinic. So I would like to finish my talk with a quote from Mark Twain: "Be careful about reading health books, so you may die of a misprint." Thank you very much for your attention.
It is really great to see as dreams come true, actually, as you were, I mean, not only the publications, but also, I mean, the methodology that you actually really plan to study and show that that's the best one, or maybe actually equally the best out of two. I mean, now you have the access to do that. Can we, in your first strategy, I mean, so you had a selection and then you get 80 studies, and then so how did you get the other 76? So these were actually redoing the selection, or what was that?
This is the selection process illustrated above. The steps illustrated above is the systematic search, and below that is the reference search.
Yeah. So okay. So that was the opposite. As so originally you find 67, and then you get another rate. Okay, fine.
No,
questions?
59.
Congratulations, a very nice presentation. I got questions regarding your second project. So you have a very clear and strong hypothesis. Could you give us some background why it should be so, some theoretical background? And also, could you give us what do you consider what would be the demand for on-demand performance of DEN?
Thank you for the questions. I could talk about this for quite a long time. So, to be short and concrete, the necrosectomy should be performed if certain criteria indicated, like the infection of the necrosis. Now I am talking about drainage, and the necrosectomy should be performed if drainage doesn't lead to improvement in the clinical condition of the patient. So if it's infected or if it's not infected but still causes obstruction of the GI lumen and corresponding symptoms to it, or pain. Even if it's sterile but causing the symptoms of obstruction or pain, then it should be drained. Otherwise, it should not. So approximately half of that should not be drained. But I think nowadays we are even more conservative regarding this, because necrosectomy is performed even less frequently than it was before. And why this is the principle? This principle based is mainly on previously published data, which decided to perform direct endoscopic necrosectomy on 1 to 4 days after the initial placement of the stent. And then usually it was performed every 3 to 4 days. This is the reason why we assume that an interval of 3 or 4 days of a regularly performed DEN is beneficial, because all of these studies resulted in better clinical outcomes compared to surgical approaches. But again, these two strategies were not compared before, whether an on-demand fashion or a regular demand fashion. But perhaps I was a bit too confusing, because there are two factors that should be decided. So whether it should be whether the intervention should be performed immediately after the diagnosis of an infected wound. Nowadays we know that it shouldn't. We should wait until the demarcation of the lesion, and when the drainage is performed, then the question is whether necrosectomy should be done immediately or delayed after 1 to 4 days. These are the aspects that were investigated before, and we know that performing necrosectomy after 1 to 4 days later, after the initial stent placement, leads to fewer necrosectomy sessions than doing it. So wrongly. Sorry, I told it wrong. That doing it directly after the initial stent placement leads to fewer necrosectomy sessions than do it after 1 or 4 days after the stent placement. But whether this should be done only in the case when the patient's clinical status doesn't improve or even worsens, or it should regularly be done every 3 to 4 days, independent of the patient's clinical status, this is, I think, a relevant clinical question that has not been investigated before.
Interesting topic, also for me. So in your first research project, you tried to analyze how to enter, after a bariatric procedure, the papilla artery, right?
Exactly.
So what is, yes, so for my knowledge, it is there are different techniques also in endoscopy. You have different endoscopy. You have Olympus. You have other scopes. Does this have any effect on your analysis? I mean, which type of endoscope is used? Because you are comparing two techniques, and you're comparing also the skillfulness of endoscopists.
3 techniques. I think you may ask about the potential selection bias caused by the indication, whether the chosen procedure was chosen just based on the local expertise or on independent data. And unfortunately, this is an inherent limitation of the inclusion of these retrospective studies. So we can say that this risk of bias cannot be adjusted for, because certainly these retrospective single-arm studies performed the chosen procedure just based on the individual experience and opinion of the endoscopist, or of course consulted with the patient as well. Maybe I was a bit too rushed, and I have not told the names of the procedures. Because the first, these are the enteroscopy-assisted ERCP is on the left figure, the laparoscopy-assisted ERCP is in the middle, and this endoscopic ultrasound-directed transgastric ERCP can be seen on the right. And this latter is the most novel one, but seems to be the most effective, or at least effective as the laparoscopy-assisted ERCP. And regarding the instruments, if you wish, you probably were also curious about that, because the enteroscopy-assisted ERCP requires an enteroscope, preferably a double balloon enteroscope, because double balloon enteroscope and single balloon enteroscopes are completely two different procedures. And the laparoscopy-assisted ERCP requires a surgical placement of a laparoscopic port, and then the insertion of a regular duodenoscope through this port. And the endoscopy, the EDGE procedure, is the combination of an endoscopic ultrasound and the placement of a stent between the bypass stomach and alimentary limb of the jejunum or the pouch under EUS guidance, and then change the scope for a duodenoscope, and then cross this stent into the bypassed stomach, and then performing a regular ERCP over that. And this is usually done in two sessions, in two separate sessions.
Your parameter was success rate. In which percentage you were able to check the papillary artery, right? This was your endpoint.
Yeah, this was.
And what about have you also the complication rate?
This is here the complication rate. It's according to previously published data, and this is what's probably the most relevant findings of our research, that it was significantly lower with the enteroscopy-assisted. The complication rates were significantly lower with the enteroscopy-assisted technique.
When you talk about complication, which kind of complication you mean?
These are the most important individual complication rates: post-ERCP pancreatitis, perforation, procedure-related perforation, and procedure-related bleeding. And by this I mean that bleeding that is not caused by the ERCP, or perforation that is not caused by the ERCP itself, but by the technique that the gateways establishes.
Congratulations for your studies, especially the first one is very important, I believe. What is your thoughts about that the enteroscopy-assisted ERCP is less successful? What are the explanations for that from your side, or from the literature review what you have done? And if you would be the endoscopist, and if you would be the patients, which one you would choose from?
Really, to start with the latter question, it really depends on the local expertise, because
assuming you are expertise in all three and everything is available,
then I would definitely go for either for laparoscopy-assisted or EDGE. And considering the better cost-effectiveness parameters of the EDGE procedure compared to the laparoscopy-assisted technique, because there have been data published about this, and it showed that the EDGE is the better in the quality-adjusted life years, and in terms of cost, it is the best basically from all the three. Enteroscopy-assisted ERCP is the second, and is the worst is the laparoscopy-assisted ERCP regarding the cost. And because if we are experienced in all the three, then I would definitely go for the EDGE. And but there are other factors that should be taken into consideration, like whether the patient received cholecystectomy before or not, because if not, then laparoscopy-assisted ERCP should be preferred. And of course, the enteroscopy-assisted ERCP could be given a shot in the case of if the limb is shorter than 150 centimeters, because the expert opinion says that longer limb than that makes the ability to intubate the duodenum very difficult.
You have very nice data. So I would like to ask you if you balance your results and with the results after bariatric surgery. What is your recommendation for the future? What is your ideal procedure if you put both results together?
The results of success and complication?
Yes. Is it possible to have management via endoscopy? And the results after bariatric surgery? If you balance both, what is for you the best procedure in bariatric surgery? Or is it not possible to say, to draw a conclusion from your data? If I'm a patient and I ask you, hey, tell me, what is the best procedure?
I think this cannot be answered just that easy. So we have to take into consideration whether the patient underwent previous other abdominal surgeries or not, because this makes
no surgery. No surgery at all. I have overweight, and I ask you, what is for me the best?
The best ERCP option for patient.
Best bariatric option.
Best bariatric procedure.
Yeah.
Sleeve gastrectomy changes the least in regarding the anatomy, and it also is associated with very promising weight loss, and it's becoming the most popular. But I think it also depends on the degree of the obesity, I think, because if a larger amount of weight loss is required, then the Roux-en-Y gastric bypass is probably the first option to choose. Maybe I was correct.
Congratulations on your results. This large font size of the p-value is begging for a question. so my question is, how does one interpret the p-value? What is the p-value, and what limitations does the p-value have, especially in clinical research?
As far as I know, p-value shows us, based on the assumption that our null hypothesis is true, it shows us the probability that this result is happening just by chance or not by chance. And when it's too low, then we should probably not refuse the null hypothesis, but reject the null hypothesis.
And what kind of limitations does it have?
The level of alpha is set arbitrarily, as far as I know, and this 5% is adjusted to the level that is accepted for the false positive cases. That is still acceptable, and even I think that if there is a possibility to misuse the P level, if some researchers perform an examination too many times, repeated too many times, then there is a possibility to find a positive or significant difference. And this is most often a cause of misuse of the p-value.
Thank you.
Congratulations on your lecture, and I especially want to congratulate you for the first laparoscopic assisted procedure in Hungary.
Thank you.
So could you tell us more about that?
I was just watching it, but
yeah, but still, like, could you tell us more about it? Do you think more will be performed, or are you planning maybe to perform? Because I think like this is basically the spirit of this program, that you actually applied what you learned in practice. So that's great.
Hopefully, I think that about between 50 and 100 Roux-en-Y gastric bypasses are performed in Hungary yearly, or am I probably wrong? Or a bit, so somewhat in that amount. So it's sure that the occurrences of biliary stone formation will increase in these patients, and then ERCP should be done. And if we don't learn how to do edge, then we should go for laparoscopy ERCP. So probably the amount of it will increase. Interestingly, the procedure itself, it's not so very complicated. It took about 30-40 minutes. Performed by an experienced bariatric surgeon and an experienced ERCP specialist.
It's also, for me, it sounds very interesting. Could you explain the procedure? What is the role of the surgeon with the laparoscope?
The role of the surgeon is to find a good access site on the stomach. He places the trocar approximately on the greater curvature at the part of the body of the stomach, or in the region of the antrum, on the greater curvature, and makes a gastropexia to stabilize the position of the trocar, and then they just wait until the endoscopy does it. Just wait.
I have a question. Do you think elective cholecystectomy should be indicated for patients undergoing Roux-en-Y bypass?
It's a very good question, because these patients have no more CCK after this procedure. According to the current recommendations, it's not routinely recommended based on previous data. More details I don't know, so what are the exact studies that this opinion was based on, but this is the recommendation.
If I know correctly, there is a recommendation. If someone has asymptomatic gallstone before obesity surgery, they need to do, or advised to do, cholecystectomy.
Of course, sorry, I meant that.
Without stones,
stone
yes.
is present.
Without stones, no need for that.
Yeah.
Interesting. How's the incidence? Because we're teaching our students that the weight loss is a risk factor for developing
weight
bile
loss
stones.
itself is a risk for stone formation, right?
And the aim is that the patient is losing weight. So how is the incidence of getting stones after bariatric surgery?
Probably it is associated with the slowment of the contraction of the gallbladder, and with the as again loss of the cholecystokinin secretion, and this leads to slower bile production and excretion. Probably this is.
I will ask you, how is the incidence from 100 patients getting a procedure like this? How many patients developing bile stones?
Good question. 30%.
30%. So maybe it's getting a good indication for prophylactic.
But the obesity itself is a risk factor for gallstone also. So majority of these patients has already gallstones who are going for bariatric surgery. So definitely those need cholecystectomy.